Welcome to the PsychopharmaStahlogy Show, a special NEI podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another edition of the PsychopharmaStahlogy Show, our NEI podcast series. And we're going to be talking today about another underutilized psychiatric drug. We did one on clozapine. And today we have my good friend, Dr. Jonathan Meyer, to talk with us about lithium. Jonathan has just written with Dr. Stahl a handbook on lithium. Jonathan, how are you?
I'm fine, and pleasure to be here with you and Steve once again, talking about an important medicine that nobody uses.
and should use more of. Steve, how are you?
I'm great.
What do you think we're going to talk about today, Steve?
We're going to be talking about a paradigm shift away from Valproate towards lithium and, basically resurrecting, if not, a brand new vista for this agent. Jonathan has uncovered a lot of truths about that in the book, and he really simplifies the understanding of the renal impact of lithium and making lithium great again? Shall we call that again?
Absolutely. Well, Jonathan, a lot of people may not realize that lithium has wide-ranging effects, including neuroprotective effects in the brain. Some people may know about the anti-suicide effects, but can you discuss this a little bit further?
Yeah, we've known for decades that lithium had some unique neuroprotective properties, well demonstrated in animal models. It was studied in animals for a number of things: stroke, neurodegenerative disorders, etc. The human evidence really came to fore in the last decade, and there's a wonderful 2020 meta-analysis by Velosa. I won't get into all the mechanisms, because lithium clearly is the sum of its parts, but the data is what I want everyone to remember. So this paper, which came out in 2020, the first author is Velosa, V-E-L-O-S-A, showed that if you keep older individuals on lithium, for at least a few years, that you reduce their future dementia risk by 49%.
My goodness.
49%. And the important take-home message is Valproate had no effect, number one. We'll hear a lot of bad things about Valproate. But also, people with a history of mania have 3 times higher rates of dementia than the general population. So it's important to recognize it's a high-risk group for developing neurocognitive disorders, and lithium has an enormous effect.
Now, what doses were being used? Is this therapeutic doses or?
Yeah, these are therapeutic doses. So, and I know why you're asking, because I can read your mind, broadcast your thoughts. There is treatment for that, but that's a different podcast.
Yes, all right.
But the idea is that if you ask me, well, what about micro or low dosing? I can't give you an answer, especially if you're a low-risk population.
Right.
But I think the point is that, when you and I trained, and I still hear this, people get taken off of lithium just because they get older.
Absolutely.
I don't know, Steve, does that seem like a good thing to do?
That sounds like a good time to start it. I mean, I'm hanging on to every piece of gray matter I can at this point in my life, so... yeah. I mean, I don't know, more brains probably better than less brains. So, increasing your gray matter is a good thing.
So, Jonathan, why are people taking them off the lithium then?
It's fear more than anything. It's one reason why Steve and I, kind of got the handbook out there. People are afraid. They understandable, when you get older, you often have declines in your GFR. It's age-related. And there's a concern that people lose their safety margin, or that lithium is inherently unsafe. But I think the evidence is to the contrary. Often what does you in as people get older is not the lithium per se, assuming it's being used intelligently, meaning being given once a day, that the 12-hour levels are always in that sweet spot between 0.6 or 0.8, never above 1. Assuming you're doing it that way, the independent contribution of lithium to renal dysfunction is modest. But what often does you in is the comorbidities. It's a group of people who have severe mental illness, bipolar spectrum or schizoaffective bipolar, lots of hypertension, prediabetes, diabetes. That's often the culprit. But to just reflexively take people off because of age makes no sense. All decisions should be made based on GFR, taking into context also the medical situation.
Well, maybe a more responsible message is, of course, as we age, it is possible our renal function may decline, particularly if we have hypertension. So just monitoring the levels, and you might have to adjust the dose. Don't just set it and forget it. I think that's a more responsible message, maybe.
Yeah, absolutely. And another point, which many people don't realize, is as you get older, often your blood-brain permeability barrier changes. And so you may be able to run people as they get into their 60s, 70s, and 80s at slightly lower levels than when they're in their 20s, 30s, 40s, and 50s. So really be mindful of that, especially if the person starts to complain that they're feeling essentially over-medicated. They're getting a tremor, they're complaining of cognitive dulling. Take that as a real complaint that they're getting more CNS penetration of lithium. And maybe this person who's always at a level of 0.75 might do fine with a level of 0.6, 0.55. Do it slowly, do it judiciously, but just kind of keep that in the back of your head that this is something to consider as people get older.
Yeah, Jonathan, when you and I trained, I would dare to say that we were really trained to use lithium. I mean, I know I was, and it was definitely something that I was very positive about. But nowadays, it's not being used as much and probably not nearly enough. Why is that? Maybe historically, what happened that kind of led to it falling out of favor?
Well, there's two trends. One of them was the rise of Valproate. It sounds like a sort of a Star Wars movie, the rise of Valproate. But that was it. And then number two is the atypical antipsychotics. And there's many people who say, well, these agents have anti-manic properties. A couple of them also have antidepressant properties. Therefore, they must work the same as lithium. But I'm pretty sure, Steve, that they don't have the same impact on second messenger systems or the same clinical profile, even though they may exhibit anti-manic or antidepressant properties.
Absolutely. And I think the other thing is you can be gentle with lithium and not drive it hard, which is sometimes how we did it. We had...
Right.
Oh, let's give it twice a day and slam them twice. And let's also give it, so who cares if once in a while it goes over 1 or 1.2, who cares? That's, not too often. And it could even run high, over 1.2 for a while.
That's right.
The idea is, wait. Softly. You can then preserve the brain and the kidneys so that when you're elderly, you can still take it. So those are some of the things. We know how to actually use it in a more gentle way. And it's, once a day dosing, and it makes sure you don't ever, if at all possible, have high levels. And Jonathan quoted right there just a minute ago, lower levels. You don't need to slam people over 1.0 all the time.
Yeah, that's certainly true. A lot of people may not realize, too, that it is recommended as a first-line treatment by many guidelines and other entities. It really has fallen into a much lower line therapy. I'm wondering if there aren't also some commercial reasons. We haven't had a branded lithium in many, many years, right? So this is Escalate and Lithobid.
Wait a minute. You're telling me that marketing works?
100% I'm saying that. Yeah.
Oh, maybe that's 100%. Part of it.
I think so.
Counter detailing works. And I think a lot of people were trained, hey, you could put them on atypical monotherapy, a couple of agents, have indications as bipolar maintenance or aripiprazole and olanzapine, and therefore it should be good enough. But I think the clinical data has opened our eyes that when you follow people naturalistically, there's these large data sets which come out of places like Sweden where you can follow everybody. The rates of treatment failure on atypical monotherapy are extremely high, including a drug like quetiapine, which is one of two atypicals, which is an indication for both acute mania as well as bipolar depression. You think it's the perfect drug.
And maintenance.
They'll do worse on it than they do on lithium monotherapy.
That's monotherapy. That's remarkable. Yeah, I remember, and Jonathan, I'm sure you do too, when the articles on Valproate, Paul Keck and Sue McElroy, of course, were really at the forefront of this. The valproic acid articles started coming out, and then there was this branded form, and a company got behind it and really started promoting it. But you're right. I think we didn't fully appreciate valproic acid. I don't think we realized the risk associated with the potential benefit here.
Yeah, some of the stuff just came out recently, and I think that's sad, but it is the way it is that people have come to appreciate some of the harms. And yes, we always knew that there was hyperammonemia and every once in a while some LFT problems. And we knew certainly there was some risk for certain physical anomalies.
Right.
But, I don't think
polycystic ovary, I've seen alopecia. You mentioned tremor, things like that.
Severe problems.
Yes, that's right. Polycystic ovary, though, can be a problem, yeah.
Not great, but we felt it was manageable.
Yeah.
But, over the last 6 years, we've had a number of warnings about Valproate, which has essentially been banned in Western Europe.
Well, let's talk about that. It turns out, specifically on March 23rd, 2018, EMA, the European Medicine Agency, issued a bulletin talking about measures to avoid valproate exposure in pregnancy. I mean, not just think about it, but you should avoid it. And then this was followed by a very recent 2023. The UK banned the use of valproate for men and women under age 55. And even more recently, February 19th of this year, the EMA issued a communication about increased risks of neurodevelopmental disorders among offspring of male patients taking valproate. Not females, but male partners. What's this going to do to the bipolar disorder landscape here, and how might this affect our use of lithium, Jonathan?
Well, as Steve and I have joked, you can't give Valproate to men or women. So I'm not sure you give it to maybe pediatric patients, maybe to your dog. But let me tell you some of the numbers just to kind of scare everyone straight out there. Women who take Valproate during pregnancy, the rates of fetal Valproate syndrome in their children exposed in utero are 30 to 40%. And mostly it's manifested as IQ loss, on average 8 points, but sometimes much more. And then a fraction of those will also have the physical anomalies as well.
Right, neural tube defects.
Time to figure out, because everyone recognizes a birth defect, the physical, but the cognitive stuff took time, and you needed large data sets to realize, hey, these people are falling off the curve of intellectual development compared to their peers. Wow. So if I wanted to put a woman under 55 on Valproate in the UK, I would have to send her to 2 consultants who would both certify she had no other option, and she had to be in a pregnancy prevention program, which is probably going to be a permanent form of birth control, meaning IUD, maybe long-acting injectable hormone. The male ban, though, was kind of a mystery. I mean, I won't say it's a mystery, Steve, because we knew that Valproate did things on histone deacetylase. And you want to explain to people what histone deacetylase is and why messing with it's probably not a good idea?
Yeah, well, your genes turn on and off due to a regulatory process in which the DNA is basically wrapped by basic proteins and called histones. And so when you actually do 2 things to them, they will make your genes start producing proteins or stop producing proteins. And one is histone acetylase, and there's an enzyme called a deacetylase. So if you acetylate things or you methylate things, it changes the expression of genes. Well, I don't know about you, but, changing gene expression messes up fetal development, and it might mess up your own development in the sense of giving you cancer and all sorts of stuff. That hasn't been found yet, but when you're mucking around with genes that are churning on and off, you don't even know which ones they are, not a good idea. And so this is a histone deacetylase inhibitor, which means you have too many acetylases on your DNA, which changes the expression of genes. And that changes the brain development, and that changes your IQ, and that changes your physical abnormalities and so forth. So that's why it could very well be that Valproate will eventually be withdrawn from the market. I doubt whether it would be actually approved today if we, but it's an off-target action. Now, and we know that it changes, perhaps GABA levels, and boosting gamma-aminobutyric acid can mean why it works in epilepsy or even migraine, let alone in bipolar. And so this is not how it works. This is how it's toxic. This is an off-target action on histone deacetylase inhibiting that enzyme, changing gene expression. Not a smart thing to do.
And we knew from animal studies it clearly caused problems in the offspring of males who were taking Valproate. Because essentially you're messing with what we call the epigenetics of what's going on, methylation or acetylation. And so when UK banned it last year, really it was based on animal data. And people thought, well, okay, we understand the concern, but the EMA data, which was accumulated and pushed out to the healthcare providers in February 19 that you mentioned, Andy, provided the first human confirmation of this. And they got a pooled data set of people from 3 Scandinavian countries. And these are people who had a seizure disorder, and they compared it to people on monotherapy of other agents which didn't have teratogenic potential. So apple to apple with a control arm.
I just mentioned, Jonathan, one of those was lamotrigine, which is another option in bipolar disorder. I just wanted to mention that.
Yeah, and there's actually data which shows that at least in the first trimester, no increased risk for major congenital malformations.
Right. Yeah.
And so they showed, and this was the human confirmation of what the UK suspected, that men who take Valproate within 90 days of conceiving a child, that child has a 50% increase for neurodevelopmental disorder, which is a relative risk of or hazard ratio of 1.5.
Right.
Now, if you do the number dated to harm, they're in the mid-60s up to 80. You think, doesn't happen that often. But the outcome is bad. I don't know, Steve. Is there a cure for autism?
I don't know. Not good.
Yeah, not good. And that's the whole point. This is a permanent problem the child will have. And, people have to know about this. And if you have men or women on Valproate, they need to be brought in. And you probably need to find an alternative, or certainly if it's a male at least, he needs to be consented for what the risk is to his offspring if he conceives a child. And so I think the theme here is that you need to know how to use lithium, because somebody has an mania in particular. They need to be on a mood stabilizer. And if you don't have lithium, all you got left is carbamazepine, and let's face it, it's a thorn in my side every time I have to use it, because all of the medicines which are approved for bipolar depression, meaning the atypicals, all go for CYP3A4.
That's right.
All of them are going to be messed up by the use of carbamazepine, and essentially you cannot use them. I can't use lorazepam, I can't use lumateperone. I'll use quetiapine, although I never want to. And
cariprazine too.
Yep, there's no data on the
aripiprazole, brexpiprazole, lumateperone, all of them. It's quetiapine also. So and the problem is, I mentioned lamotrigine earlier. Lamotrigine's not a very effective anti-manic. That's the point. It's better for maintenance and maybe bipolar depression.
Right.
I sort of cut back on prescribing Valproate years ago because I've really had a patient say, "Oh, thank you. I feel so much better. I feel great on this Valproate." What happens is they say, well, I'm not manic. That's about it. Whereas I've had people on lithium say, I feel great, thank you. I've definitely had that, particularly if I don't run it super high, like Steve said.
Yeah, look, lithium has adverse effects, and we'll get into that, but you keep the levels modest. And when people complain of cognitive dulling, and they're not depressed, and they're not also on quetiapine or something else, which is making them impaired, you have to respect that, and then just consider that this person may be getting more CNS penetration than the next one for the given level, and maybe run it a bit lower.
One other important piece of information, we made it sound like, well, Valproate's a problem then in people of childbearing age. But as people get older, I'm actually an author of a paper. We did a study of valproic acid to treat essentially agitation associated with dementia in nursing home patients. We saw quite a bit of bleeding problems and liver problems and sodium problems. I was surprised how tolerability issues in the elderly. So it's not that you're out of the woods once you're out of the childbearing age either with valproic acid.
And as we mentioned, there's zero neuroprotective effect. The neuroprotective effect of lithium is seen within the first year of exposure. In older bipolar patients who remain on lithium at least 11 months, you already start to see the treatment effect. And you don't see any effect whatsoever for Valproate.
So what we're talking about is not only clear benefit in acute mania, but clear benefit not only in the stabilization and maintenance of the illness, but also these neuroprotective effects, an anti-suicide effect, which of course is the worst outcome. So I guess then what are the potential consequences then of not using more lithium for patients and our public health?
Poor outcomes. There's a wonderful study out of Sweden which just shows that the rates of treatment failure, you can just look at the monotherapies. Lithium is the best. Everything is worse than it. Valproate and all the atypical monotherapies are worse. Now, we have to recognize that bipolar disorder, especially bipolar 1 or schizoaffective bipolar type, is a complex illness. Most of these people will end up on 2 medication.
Yeah.
As much as I love lithium, not a great acute antidepressant. Most people will probably need a second drug, at least for bipolar depression, and sometimes another agent to help out the upside. But I think the cognitive distortion around atypicals is pretty large out there. And people mistakenly think, well, they're approved for maintenance monotherapy in bipolar 1, therefore aripiprazole monotherapy is sufficient. And the naturalistic data indicates that, yes, it's better than placebo, it's probably better than nothing, but it may make your life easier as a clinician because you don't have to get levels and monitor other things, but that's not in the best interest of your patient. So I want to give you all a quote before we go on to other things. Famous data psychiatrist Moen Scout did all the early lithium studies in Europe once they heard the news from Australia about its anti-manic property. And he used to write a manual on lithium every few years. And he has this great quote from a patient. The patient said, "In the past, when I was manic and you gave me what he called a neuroleptic, it was like my foot was on the gas and on the brake at the same time. When you gave me the lithium, it turned the ignition off."
Wow.
So think of atypicals in particular as great suppressors of mania, but maybe not a treatment for it. Yes, some have antidepressant properties, but that's, I think, a really telling example of that. All of these second messenger things that lithium does are really manifested clinically in rates of treatment failure and experientially by the patients who have taken these agents at different times.
I'm reminded of a term that Dr. Stahl taught me himself many years ago called rational polypharmacy. And it seems to me adding lithium to an atypical is very rational. I mean, there's not too many drug-drug interactions there, certainly pharmacokinetically. So it really seems rational also therapeutically in what it's doing. Would you agree?
Yes.
Yeah, I think that the idea is that the atypical antipsychotics are probably best for the downpole of depression at the lower doses and to reach into getting a better anti-manic as well as preventive from mania, get you into these higher doses, which are less tolerable. And so many people are running around on lower doses really with very little manic protection. And of course, the illness is fundamentally a depressive illness, so it may take years for you to actually have that show up. But, sprinkling some lithium on the top of an atypical for many patients is not done. And too much Valproate. I think that by the end of this podcast, people will begin to have, this is not an inconsequential subject. In other words, it's stuff like stop using Valproate, start using lithium, but use lithium once a day and keep the levels low. I mean, that's a huge change. If we would go back, if you go back to your charts and look at, you inherit charts and maybe your own charts, but go back and look at how often you don't use lithium, that you do use Valproate, and when you're using lithium, how you use it, and just change the way you use it, and you're going to get great outcomes. Let alone the suicide effect and the neuroprotection, which Valproate and the atypicals don't have.
Yeah. Well, as a matter of fact, guys, there are several atypicals that are FDA approved to use with lithium in acute mania. There are even 2 that are approved in combination for bipolar depression, and that's lorazepam and lumateperone, the newest one. So we actually have evidence, and we have FDA approval to do it. So, and guidelines tell us to do it. So maybe we do need to do it more. All right, let's move on then to a couple of other things. You alluded, Jonathan, to the safety issues, and I certainly was trained to worry about the thyroid, to worry about the kidneys, to worry about other things, to worry about the bone marrow, let's say, and sodium, all this stuff. What are some of these myths and misconceptions? What do we really need to understand about lithium's safety?
Yeah, I mean, the primary concern is renal dysfunction. A lot of that was the product of how we did things in the past, giving lithium more than once a day, allowing levels to be too high, all of which exert a toll on the kidney for no benefit whatsoever. Lithium in your brain, everyone, has a half-life of 28 to 48 hours. There's no reason to ever give it once a day. Unfortunately, lithium was approved over a half century ago. The package insert still says give it 2 or 3 times a day, which is a product of how people did things in the 50s and the 60s. Well, it ain't 1969 anymore. In case you didn't know, and we don't do things the way we used to in 1970. So that's a big part of it.
Jonathan, you've talked a couple of times here about the once a day. Maybe we should explain to the clinicians it's a little counterintuitive. You would think giving a little bit a couple times a day would be better for the kidney than a higher amount once. Help us understand why once a day is better.
It seems like, well, basically it's on the clinical data. So I'll just say that straight off. We make all of our decisions on lithium based on the clinical outcomes. But the theoretical issue is that if you keep the trough too high throughout the day by giving it multiple times, you're probably having more lithium passage through the kidney. And where lithium causes its problems is it gets into this epithelial sodium channel, which we call ENaC, E-N-A-C, epithelial sodium channel, the collecting principal cells, and that's where it causes all of its problems. So giving it once a day, there's probably one big pass through that, and then maybe it allows those cells to perhaps clear some of the lithium which has accumulated. But when it doesn't get cleared, and this is the important clinical take-home message, the first sign of that will be the patient complaining of, I'm peeing too much. That is a red flag. I mean, that is like smoke coming out of your basement. You don't ignore that. You must treat that because it's the sign of future things that will happen, which are not good if it's not treated. But we're fortunate. There is a medicine out there which will block lithium getting into these epithelial sodium channels, or ENaC as we call them, and that drug is amiloride. It has a own mechanism of action. Amiloride is an ENaC inhibitor, and we are fortunate that it exists, and it will block lithium getting into those cells. So if the person complains of polyuria, you put them on amiloride, but you want to do it as soon as possible for two reasons. Number one, people like to pee a lot. I don't know about you, Steve. I like to pee a lot. Don't get up at night and pee. No one has to go to the bathroom 6 times a day while they're at work. And so they'll say, I don't want to take lithium anymore. Then what are you going to give them? So that's number one. And number two, if this process is left for years untreated, that's where we see a lot of the downstream problems of microcyst, interstitial fibrosis, all the bad things that people blamed on lithium.
So, Jonathan, are you saying to co-initiate amiloride with lithium or wait for the polyuria?
Yeah, I don't think the data are at the point we're going to use it prophylactically, because not everyone does get polyuria. There's some people who seem to be more susceptible than others. But as soon as the patient complains, and the best screening test for, I don't know if you know this, Steve, there's a great screening test for polyuria. It's called talking to your patient.
Can I bill for that?
I think you can. But you got to ask people on every visit, and then as soon as they say yes, you got to jump on it. And I give in the handbook some ways to measure it without having to do a 24-hour urine collection and how to use amiloride to treat it. But this is your friend. The sad part is when you see people who have with this been untreated for years, what happens is those principal cells die. And then you finally treat it. And yes, the polyuria would get better some, but there's not enough of the cells left to absorb all the water. And then you have to do additional tricks to try to reduce the extent of urinary volume. So it's best treated early for a number of reasons.
Well, there's a generation of patients out there who, I think you mentioned it, Jonathan, they get polyuria and then they won't take lithium. And they deprive themselves of lithium and they never had a chance to take amiloride to fix it. And there's another generation of patients out there who just keep their polyuria going, and they don't get amiloride either. I would wonder if there's ever, it'd be useful to take one of those Medicaid databases and ask how often is amiloride co-administered with lithium, but I'll bet it's very low. And that's something that really is a tool in a psychiatrist's hand that will get you to prevent problems in patients that can tolerate their polyuria and get people to stay on the med that can't tolerate their polyuria. And we don't do that. That's really amazing.
Yeah,
guys, that's one of the many nuggets. This book is chock full of nuggets, Jonathan. It's really a remarkable achievement. You've summarized a tremendous amount of information here. It's very
Let me give you a statistic to back up what you were saying, Steve, that there was a study out of Dublin where they actually helped us find some tools to track polyuria in lieu of the 24-hour urine collection. But they saw in clinical practice that only 3% of patients who had polyuria were given evidence-based treatment, which is amiloride. That is the one evidence-based treatment. Either people were taken off of lithium, not good,
Right.
or they engaged in ridiculous things like dose reduction, also not good. There's no evidence that dose reduction is a way to treat polyuria. So learn how to use amiloride. If you've never heard about it, read up on it. Yes, there's some monitoring you might have to do if people are on other drugs, which are ACE inhibitors or are mostly for hyperkalemia, but it has a specific mode of action. And to your point, Andy, it might be within our lifetime, maybe we will consider the prophylactic use of amiloride. I don't think we're there yet, but I think everyone who uses lithium needs to know how to use it.
Well, just knowing that, I'm sure most of our audience doesn't know that. And Jonathan, frankly, you taught me that. I was not taught that. I didn't realize that. Amiloride's a medicine I was familiar with from my internal medicine residency, but I hadn't used it in many, many years. So that's one of just many tremendous things. I mean, if nothing else from this podcast, if people give the dose all once a day, I guess preferably in the evening, and know how to use amiloride, then they should be really comfortable. Now, we started talking about some of the safety issues. Jonathan, how about you address some of those other issues, and especially the myths?
So a couple things. You said sodium. There really is not an impact on serum sodium. There is an impact on the bone marrow, but it is neutrophil counts. It's benign. Right. Sometimes we actually exploit that in people on clozapine. But you know what the people should know, because the poor primary care provider who maybe not at the top of their class, like, oh, you have an infection, and they'll start doing it to them unless they realize that lithium induces neutrophilia. When you give lithium, it's like giving a colony stimulating factor. It directly increases the number of neutrophils out there. I was taught some nonsense about demargination of polys.
That's what I was just going to say. Bull hockey.
Yeah, that's a good way to say it.
Yeah. No, that's what I was taught too, Jonathan, when I was medical director of a clozapine clinic. That's what we were told. Demargination.
It's wrong. It actually makes more cells, so more neutrophil.
Good.
Yeah, does it cause hypothyroidism? Hypothyroidism is one of the more easily treated adverse effects of lithium. It's not a reason to avoid lithium. If somebody's hypothyroid, it's not a reason to take somebody off of lithium. And again, Steve, you didn't come off of lithium and they have a history of mania. What are you going to give them, right?
Right. Jonathan, how common is the thyroid problems, hypothyroidism with lithium?
It's more so in women than men. It's somewhat duration dependent. So, I mean, the numbers are probably in the 20s, over the lifetime, maybe a little bit higher. It's just one of those routine things you monitor every 6 months, along with the GFR. All decisions about renal function these days are made by GFR, not by creatinine. You monitor the TSH. And the only other thing people maybe have not heard of is monitor serum calcium. Lithium just alters your set point of calcium sensing. And so you tend to run a little bit higher because it's kind of messing with the thermostat if you want to think about it. And it's a small number of people, you might get some parathyroid adenomas. But the idea is you monitor it routinely. If you see a problem, it gets picked up. Again, easily treated. Some people do need surgery, but often we can actually give them a calcium analog. See, these are called calcium mimetic drugs, which just move the set point back to the other side. And it's called cinacalcet is one of them, and allows us to manage this problem, I would say, fairly easily.
Yeah. That's extremely helpful. Thank you very much for that. There's probably many reasons why lithium is not used more. Certainly, a lot of younger people are probably not even trained how to use it, to be honest. I think they don't understand all the benefits. But I think also people are a little concerned about, I'm worried about running this narrow therapeutic window. I've got to get blood work. Patients are going to tell me they feel dulled. They don't like taking it, this kind of thing. So how do we address those things?
I think when people have a history of mania, you have to let them know this is the best treatment for their brain. And as always, people will do what they want. But you have to give it to them honestly and not prejudice them because it's easier for you to not use lithium. That to me is just, I think, is unethical, to be honest. It's like telling somebody who's treatment resistant, let's try the new antipsychotic because it might work for resistant schizophrenia, even though there's zero evidence because the person doesn't want to prescribe clozapine. Exactly. To me, I find that really abhorrent, to be honest.
It's very analogous.
Yeah, so I think the idea is you have to say, look, if you have a history of mania, being on atypical monotherapy is not in your best interest, and develop confidence in using lithium so you can say, I know how to use this medicine. We know how to use it better than we used to. And, as always, patients will do what they want, but you have to be honest with them that atypical monotherapy is probably not in their best interest. and just develop your confidence in learning how to manage some of these adverse effects, talking to people about various things and treating them.
Well, the concern about blood work is interesting to me because we have to get blood work with atypical antipsychotics, right? We're monitoring blood work with most of our medicines, or we should be.
Yeah.
Even SSRIs, we should periodically be checking a sodium at the very least.
But I don't know. Do you really think that there's a religious adherence to monitoring lipids, etc., and tardive dyskinesia or whatever with atypicals when they're used for mood disorders? I don't know. I mean, when you're in an institution like the VA or a state hospital, those are kind of criteria that are there, and you kind of do it rotely. But in private practice, I think there's a lot of unmonitoring that's going on.
Yeah, well, that's clearly true. There's actually data to support what you're saying. But still, the point is the evidence base and good clinical practice is that we should be monitoring certain things. So the blood work issue we can probably talk about. The part of this dulling issue might get back to, Steve, what you were talking about earlier, that people have been used to giving it several times a day, blasting away, running higher levels, and that's going to cause more cognitive issues, right, Jonathan?
Yeah. So let me give you all some math. So most of our decisions are based on levels when Lithium is given 12 hours before the level is drawn. And that's why we preferentially give it at night so people can go to the lab in the morning. Sometimes I took the Lithium 8 a.m. I don't know what labs open at 8 p.m. Maybe there is one, but it didn't work out well. The point being is that if I have somebody, let's say, on 600 milligrams BID, and they get a level the next morning, well, it's only a 12-hour level for half the dose, right? The other half has had 24 hours to clear. And so the number you're getting is distorted by that. So let's say the person has a level of 0.7 on BID dosing. Well, that number, if they took that same dose and they mashed it all to QHS and they got a real 12-hour level on the entire dose, you'll realize that number actually is 28% higher. And I think that was part of the problem with BID dosing is nobody did the math and they just said, oh, I'll use the BID level the same way as I'd use a QHS level. Well, that's just wrong. Right. It's wrong by the laws of kinetics and mathematics.
That's right.
I think that's part of the problem is we were just running people at toxic levels because folks didn't do the math. And so if you have people on BID dosing, you could just multiply times 1.28, and that's your true level. That's where they're at.
What it also means is those of you out there that are giving BID, don't just take the whole dose and give it at night. You may do that, while you're trying to rejigger things and get a level, but the reality is you're probably going to lower the dose at night a little bit from where you were BID. Yeah. So, the reality is let's just use lithium correctly.
All right, Jonathan, how do you do that? How do I convert from BID to QHS?
So first thing, I do the thing which none of you want to do, which is I talk with the patient. I know, I have to do levels and talk to the patient. It's just too much. But you have to say, look, we've been giving it to you twice a day. Look, admit your fault. Say, look, we've learned better. This is not the best thing for your kidneys. And because we're giving it you twice a day, the level we're getting is a little bit distorted because some of that medicine has been there for 24 hours. So we may be giving you too much. So once the person's having a side effect, I'd say, let's just mash it all to bedtime and repeat the level. So there's no changes made, and the patient has some time to adjust to the fact. And then, of course, the level will go up by 28%, and they'll say, let's see if we can lower your dose to an amount which gets that leveled ideally below 1 and even perfectly between 0.6 and 0.8. But the idea is the level goes up, but they're still taking the same dose. And that's where people think, it's the level's so much higher. You haven't changed the dose, right? It was the math problem that you had never solved before. But you have to let people know we maybe have been giving you a bit too much, and let's do things better, as Steve says.
Well, wouldn't you just cut the dose by 25%? Cut the dose by a quarter when you give it once? Or do you think it's better to check the level?
Some of the patients may balk at that. So that's why I say you just got to use your kind of rapport with them and explain the situation and say, because the idea you're going to change something or take something away, for many people, stable really may freak them out a bit. And I would say, look, let's just mash it all. Let's see what your new level is. Look, I can do the math. I know what it'll be, but at least you'll show it their satisfaction. And then let's make a small adjustment. That's usually the word I use. Let's make a small adjustment to get those levels a bit lower. We're giving you too much. You probably didn't need that much to begin with, and a little bit less will be easier on your kidneys.
Well, that's sound psychopharmacology principles to do one thing at a time also. You don't want to necessarily change two variables at the same time, so I like what you're saying. It really seems to me that people confuse pharmacokinetics and pharmacodynamics, and they also strongly confuse the issue you said earlier, which is the plasma level versus how long it stays in the brain. And we certainly know there's a lot of medicines that have short half-lives in the plasma that we're traditionally were giving 3-4 times a day. Quetiapine comes to mind. And then we realized, no, wait a minute, you only have to give it once a day and it's hanging around in the brain. So that little fact you just mentioned about the half-life in the brain being over 20 hours is really helpful.
Yeah, absolutely. I mean, that's what it comes down to. There was never a reason to give it more than once a day. It was just an artifact of history. Probably to spread it out because you get maybe a lower rate of GI side effects in some people, but even the GI side effects are not insurmountable. I mean, the rates are probably under 10%. So here's the rule of thumb. If people have nausea on standard lithium, maybe give them an extended release preparation, which kind of smears out the absorption, lowers the Cmax as well. Now, if people have diarrhea, it means the ion's being delivered too far south. And then if they're on extended release, go back to standard lithium. And if they still have the problem, here's the great sophisticated solution. Give it with dinner.
Give it with food. Okay. That sounds good. Well, that's another great tidbit. The difference between nausea, a proximal issue, and diarrhea, a distal issue. That's another one of those wonderful tidbits that can be found in this handbook, the Lithium Handbook. Steve, are there other things that you would suggest to clinicians that would help them to kind of get over their reluctance?
Well, how about preventing suicide?
Yeah, we need to talk about
give me a list of the drugs that do that. Maybe clozapine and another disorder. Okay. Yep. All right.
Two.
Anything
There's
else?
Two.
So, the reality is between the neuroprotection, that's one thing, but the anti-suicide, that actually bites two ways, which is that I don't know that there's really good data on this, Jonathan, but you said it takes about a year to get the anti-suicide effect, I believe. But how long till you lose it? So if you lose your prescription, you become suddenly non-compliant because you don't like your doctor anymore or whatever. I think it's much more precipitous than that. So what the Lord giveth, the Lord taketh away, I guess. So if you're not careful and you stop your lithium, you can lose this anti-suicide effect, I think, quite abruptly. Mm-hmm. So, it's something to bear in mind and to tell people about, prepare them to not precipitously stop their meds. But what do you know about the stopping of this and the starting? I mean, let's talk about the suicide, Jonathan.
Yeah. So a couple of things, as most of you know, it's sometimes hard to show this in prospective studies because once you put people in the studies, bad outcomes all automatically drop because people are being watched and cared for. So the number of completed suicides in prospective studies is almost zero. So it's sometimes hard to show this with a randomized double-blind study. So bulk of our data is based on retrospective analyses, but the signal is very clear in a way that it's not for Valproate. So I think that's the take-home message. But as Steve's point is, it's not an instantaneous effect. I put you on lithium today, and therefore tomorrow all will be well. It takes time for lithium to do its thing, and the best statement is it will reduce the risk of completed suicides and serious attempts. It has no demonstrable impact on suicidal ideation per se.
Okay.
The data are best on completed suicides and serious attempts, not parasuicidal acts, serious attempts. But it's not an instantaneous effect. And looking at the retrospective data, it probably does accumulate over the initial year to year and a half. So don't think I put you on lithium and my work is done. You just have to be aware of that. But to your point, Steve, your friend and mine, Ross Baldessarini, has looked at all those studies about stopping lithium. Do not stop lithium abruptly. When people stop abruptly, they have much higher rates of recurrence than even if you delay over a month, meaning you taper it down over a month. Just that difference between those couple of extra weeks really seems to have an impact. And the idea is probably there's some homeostatic mechanisms which can slowly accommodate towards the declining lithium levels. But if you take it away quickly, you lose that. Ideally, of course, if you have to stop lithium, and sometimes you do, you have another mood stabilizer on board, hopefully one that you're allowed to use safely.
Right.
But don't stop it abruptly. There's very few reasons why you might have to, but if you do, try to delay it over as much as a month. It seems to make a big difference in recurrence. And one thing I want to add in terms of discontinuation, one thing we've learned about lithium is the rates of major congenital malformations with first trimester exposure is much lower than we previously estimated. And as you all know, the big risk was a cardiovascular anomaly called Ebstein's.
Yeah.
But the number needed to harm for lithium exposure in the first trimester for one additional case of a cardiovascular malformation is 83.
Wow.
83. And so that means I have to treat 83 women with lithium compared to a bipolar group not on lithium to have one extra case. And unlike autism or fetal Valproate syndrome, this is a treatable and fixable problem. And so many women simply cannot do without lithium for an entire trimester. There are some who can, and maybe they, for 12 weeks, can be on a typical monotherapy or, Andy, as you said, lamotrigine, if you have enough lead time to start it before they get pregnant. But do not flexibly take people who get pregnant off of lithium simply because you're concerned about that. If the woman's brain has told you she needs lithium for 3 months, then you should continue it. And then, of course, give her the appropriate advice regarding that and make sure she has the appropriate follow-up.
Right.
As I'm listening to this, Andy, I don't know if you're having the same feeling, but, this is very cool in the sense that if you're listening and you want to actually try to be distinguished in your community among your peers, being known and being confident about how to use lithium in the modern world will distinguish you. And, it's going to take a while for all this to penetrate practice. There will be a lot of bad use of lithium, I think, unfortunately, for a long time. That's why we do these podcasts. But we're looking for some of you out there to be pioneers, to say, and what's in it for you, of course, is not only it's going to take some effort to do some work to try to read this stuff and understand it and rejigger your practice. But that's cool, because otherwise you get bored and you're, doing the same thing over and over again. This is not a new drug that you're just going to give and, you have a shiny new object to give before your peers do. That's not hard to do. But what this is, it takes some skill and, developing your skills, enhancing your skills, and also it's going to get you referrals, because how else can you get people coming to you by developing a reputation that you know how to use lithium when the others don't? So I am hoping that this could transform your practice in a way and make you more competitive, get you more patients, and do a better job with it. So there's very few times that we can actually give a podcast and really have a transformative type of potential experience for you.
That is extremely well said, Stephen. You said it at the very beginning. This is potentially a paradigm shift for a lot of people, and I think a real eye-opener. I mean, Jonathan, there you've addressed another one of these myths about the safety concerns. I think we should be responsible in another way, though, guys. We need to talk about the issue that you mentioned earlier, Jonathan, about nausea and diarrhea. If somebody does develop nausea, diarrhea, gastroenteritis, or any other dehydrating condition, remember that lithium is handled in your body like sodium, and the blood level will go up if you get dehydrated. So I think hydration, we need to preach the importance of hydration here, and particularly if somebody develops one of those conditions, they need to hydrate. And what else, Jonathan? How would you handle that?
Well, the most important thing is that if somebody has a lot of vomiting or diarrhea, or you actually go outside and they work, or they exercise vigorously and they sweat a lot, they're losing sodium. The most important thing is they have to replace themselves with an electrolyte solution. That's the key to life right there. Do not just drink plain water, because you'll dilute out your serum sodium, and as you said, lithium will be preferentially reabsorbed proximally, and that's how people become toxic. So somebody wants to go out and exercise in Las Vegas, Steve, right, the way you do, or 20, go out for a run, they must replace themselves with an electrolyte solution with sodium. If people are throwing them, they have diarrhea, do not just drink water. Pedialyte comes in 50 flavors these days, or some other version of that. It comes as powder, also with the colors.
One of those sports drinks, would that work too?
Yeah, you got to get the sodium, though. That's the most important thing. Do not just drink water. Of course, if the vomiting persists, maybe you'll have them give you a call. But most of these things are time limited over a day or so. Right. But that's really the key more than anything, is you just educate people about that.
Okay, now let's get back to benefits for a second. We've talked a lot about the benefit of multiple benefits. We've talked about addressing safety concerns. Jonathan, what about aggression, agitation, impulsivity? Those are things that sometimes lithium is associated with. Is there any evidence about that?
Yeah, I would say as much as I love lithium, the quality evidence in those areas is not strong. And people have looked at it in individuals with intellectual disabilities, sometimes in pediatric populations. I would say in general, maybe not the way to go unless there's another evidence-based use of lithium. I think part to Steve's comment about rational prescribing and being excellent is knowing where the data aren't great. And that's why, as we've talked about, a lot of people on lithium will probably get depressed if they're bipolar 1. It doesn't mean lithium is a failure. It means bipolar 1 is a complex illness. And people often need extra medications to manage all the pulls of the illness. So I would say that's the one area where I think the data aren't strongly supportive of lithium, and you should consider other strategies.
So that's agitation, aggression. What about impulsivity specifically? I mean, some people think that might be part of the decrease in suicide.
I would say not, again, strongly supported by the data. So we see the benefit in anti-suicide. There is data on aggression, some of this groundwater data, meaning the municipal water supply, which is high in lithium. You see less homicides and suicides. That's great, but I wouldn't consider that a reason to put people on lithium, preferably unless they had some other indication.
Well, the issue may be effective treatment of the illness, is going to cut down on some of these bad outcomes. Mania is associated with aggression, agitation, and, other things. Steve, I am reminded of one of our famous focuser videos, and that is the Lali video. And all of a sudden, Jonathan made me think about another rational combination is lithium with lamotrigine. And I'm sure a lot of people are a little bit afraid of doing that or uncomfortable doing that. Jonathan, what advice would you give?
I'm not sure why they would be afraid. I mean, as you said, they have different pharmacodynamic properties. We combine lithium with anticonvulsants all the time. People need lithium and Valproate for control of their mania. Sadly, we can't use Valproate too much anymore, but there's nothing about safety that would preclude you from doing it. We've done it for 25 years. Lamotrigine, it's a maintenance drug. If you're manic, it's going to do nothing for you. It may have some maintenance benefit for preventing mania, not a lot. Its niche really is preventing your next depressive episode. I sometimes have people on the 3 Ls. The 3 L come lithium, lurasidone for the acute bipolar depression, and then lamotrigine for maintenance to prevent the next depressive episode.
Well, I'm just thinking, Jonathan, if we use Terry Ketter's conceptualization, lithium stabilizing mood from above, if you will, lamotrigine stabilizing from below, that may allow us to not have to use atypical antipsychotics, avoid some of those long-term issues such as tardive dyskinesia. Maybe some people might need a little sprinkling of an atypical antipsychotic, but our audience may be learning that, hey, maybe this is a combination that's effective and I can get away from that. What do you think?
Yeah, absolutely. Look, I think atypicals are a very useful tool for acute bipolar depression. Those are going to be the go-to drugs. Lamotrigine could be used, but if somebody's depressed now, maybe they'll be undepressed in 2 months. A lot of people don't like that, and they want to be undepressed sooner than later. And certainly we have LAI options. Occasionally, Steve, I don't know, some of my patients don't always take lithium. In your practice, I think all your patients are adherent though, right?
Yeah. I wonder why you guys can't get your patients to 100% take their meds like I can. I don't know.
Yeah. So there's evidence-based use for LAIs, even in bipolar 1, certainly for schizoaffective bipolar type. But lithium is the foundational drug. Every guideline, every treatment recommendation, consensus paper, most recently the VA guidelines of bipolar disorder, which came out in 23. Again, lithium is number 1 for maintenance, number 1 for acute mania. It has unique properties which no other agent does. It's really the core element upon which you add other things for optimal stability over time.
Guys, I suspect, too, that adherence may be better now with this trick or tip we're giving people. It's a lot easier to take drugs once a day than 2 or 3 times a day. So I suspect adherence might also be better with once-a-day dosing.
Yeah, and just learn to manage the adverse effects. If people complain of tremor, well, then treat it. Or possibly may shave down their level a little bit. If they complain of cognitive dulling, take it seriously. I mean, you just have to learn to be responsive. But your theme in communicating with people with a history of mania specifically, and I'm very specific on that wording, is that this is the best drug. Let's try to make it work, because without it, you're probably not going to do well, or we have limited access to the other option, Valproate. Under rare circumstances, can we use it?
Jonathan, what about bipolar 2 patients? Does it make sense to use lithium there? I have done that.
Yeah, that was another whole podcast, because bipolar 2 is a spectrum unto itself. You know, Higgo McKiskell of now blessed memory, who's at UCSD for many years, Steve knows him very well, gave us the whole concept of the bipolar spectrum. But bipolar 2 is a spectrum unto itself. There's some people, a few, who could take traditional antidepressants for a while, as you've taught me, Andy, and Terry Ketter from Stanford said. After a while, they tend to look a little rough around the edges, so to speak.
A little roughening, yeah.
But for a while, maybe they can do okay on an SSRI, NRI. There's many people, though, who need to be on a medicine for bipolar depression. Lumateperone now has indications for bipolar 1 and 2, and that's fine for them. They're just depressed, and lumateperone monotherapy is sufficient for them. But then there's the third group who need that plus a mood stabilizer. Do all of them need lithium? Not necessarily. I'm very sanguine about this. Could they be okay on lamotrigine as a mood stabilizer? Absolutely. But for some, lamotrigine is insufficient. So I think you should consider it. But the strength of the data is modest, because there's not a lot of studies in bipolar 2 with lithium. Does it work? Sure. Is there a large amount of data supporting that? Not as much as there is for bipolar 1.
Yeah.
Well, there's even less data, although there's some European, I've had some communication with some lithium experts from Europe about mixed features, where you have some mania with your depression. And, of course, people slide back and forth, where they get more and more mania, they get less and less mania, more and more depression. You know, the real patients are not stable from one visit to the next. And so decorating them with a bit of lithium, that when they have manic features, is something to consider, although the data actually showing that it helps manic features in mixed depression is not robust. But the better data actually probably are atypical antipsychotics for the mixed features patients. But if you're not getting a good enough response from an atypical, you could consider augmenting it. It makes some rational sense. There's anecdotes, but not a lot of data.
So we've talked earlier about some myths around lithium. I'm going to give one more myth before we wrap up. Another myth is that lithium doesn't work in rapid cycling bipolar patients.
Exactly, right.
So here's the take-home message out there in radio land. Nothing works well in rapid cycling bipolar patients. They are a very sick group. The couple of studies that were done by Joe Calabrese show that lithium is not inferior to Valproate, but people do poorly. It's the nature of the illness. They're very sick people, but people do respond to lithium adequately. It's not worse than other options, but more of these people are probably going to need extra medicines and, of course, get them off the traditional antidepressants, because sometimes their rapid cycling is iatrogenic.
That's right. Now, you know, I was certainly trained that lithium is the original augmenter for depression, for MDD. And I'm wondering, is there possibly some antidepressant effect, or maybe long-term preventing depression, or are we just picking off some bipolar spectrum people when we add lithium? What do you think?
Well, if they're rapid cycling, obviously they're bipolar spectrum. But for the unipolar patient, it works with just traditional unipolar major depression, where there's no evidence of mixed features that we recognize today. Is it our preferred strategy? I would say realistically, maybe it's not number 1 or 2 in the algorithm as much anymore, but certainly a tool to consider for those people, especially to Steve's point. If they do have some mixed features, it might be something to really strongly consider, even if they're unipolar major depression.
Well, I'm talking about there's so many people, though, who have a depressive episode, not necessarily with mixed features, who probably historically have bipolar. They're just not good at reporting past manic or hypomanic episodes. And I'm wondering if some of those were picking off, or maybe you're right. Maybe it really does work in augmentation. So, you know, again, another way in which it may be underutilized is what I'm thinking. I'm just concerned. I'm a big fan of the atypical antipsychotics in the right situation, but we all know there are long-term risks, and tardive dyskinesia for me is a ticking time bomb, and is something to be careful about. Well, there's no completely safe medicine, certainly not in long-term use either. Gentlemen, I feel like we've just scratched the surface. I feel like there's so many more wrinkles to talking about lithium. I think that people need to strongly consider this wonderful book that you two have produced, the Lithium Handbook, for more details. And Jonathan, one of the great things about you, besides your incredible ability to summarize a lot of data and comb through the literature, is your ability to provide real practical guidance and practical guidelines. So I want to thank you on behalf of the audience, and I want to just give you another opportunity. Any final thoughts?
If you have a history of mania, you should be offered lithium, period. This is the foundational medication. Whether you're bipolar 1 or schizoaffective bipolar type, you're going to do less well if you're on atypical monotherapy. And because of the recent developments in our understanding of the reproductive harms of Valproate, you really need to get good at using it. And it's not that difficult. A little bit of reading, as Steve says, a little bit of practice, you can become your local expert, and people will flock to you because we'll see other providers who will give them disinformation or give them reasons not to be on it, and their patients won't do as well as yours.
That's right. Steve?
Yeah, well, I think you're right. It's scratching the surface, but it's exciting to be able to, figure out how to do psychopharmacology better, and with old tools. Old wine in a new bottle, or whatever you want to call it.
Yeah.
So, and I don't want to shamelessly peg our book, but really there is nothing like it right now, and this is really Jonathan's masterpiece, and I thank him as well for doing this. It's a sort of a thankless task to spend the kind of time he did, and but it has a transformative potential in our field. So it won't be transformed unless you guys and gals listening here actually adapt these principles and use more lithium as needed, not more than it's needed, but it's a tool in your practice to help your patients.
Well said. And Jonathan, you said one final thought here, and it kind of made me realize it's sort of like LAIs. To not offer something that is this evidence-based, to me, seems like less than the standard of care. So we should be offering this option. Even if you don't use it as often as possible, you at least need to offer it. I think it's just the standard of care. Would you agree?
Absolutely. Look, I'm a realist. Some patients will say, I don't want to take it despite all of your discussions, but they need to hear about it. Then maybe after their next manic episode, they'll consider it at that point. And you just have to say, look, I don't think it's in your best interest to be on atypical monotherapy if you have a history of mania. And, people will do what they want as always, but at least they need to hear the evidence from you that you don't think it's in their best interest to avoid a mood stabilizer. And if you have a history of mania, lithium these days is the mood stabilizer.
Right. Well, guys, thanks so much. And I want to thank you, the audience, for listening. And of course, for more episodes of the Psychopharmacology series. We've now been doing this for a few years, and there's some terrific episodes. Wherever you get podcasts, you can find them. You can either search under Psychopharmacology, you can search Stahl or my name, and we have a channel that is NEI Psychopharm. And certainly you can go to our website for more of these podcasts and other educational offerings, and our website is NEIglobal.com. Thank you so much. Until next time.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.